Imagine for a moment going through this really profound medical process. Like you're fundamentally trying to align your physical body with your gender identity,
Right?
and you're taking a medication that is quite literally saving your life. It's improving your mental health, curing your distress, and finally letting you feel at home in your own skin.
Yeah, it's completely transformative.
Exactly. But then the side effect creeps in. A deeply painful, invisible physical condition develops. And when you finally sit down in the exam room, your doctor looks you in the eye and tells you that the absolute most effective cure for this new pain is, well, the exact hormone you've been intentionally suppressing for years.
I mean, it's arguably one of the most intense medical paradoxes a person can face.
Yeah.
You are asking a patient to intentionally introduce a hormone they deeply associate with psychological distress just in order to treat a very real, agonizing physical distress.
It's wild, and today we are diving straight into that exact paradox.
Mhm.
Our mission is to look at this fascinating, highly specific corner of modern healthcare. We're looking at how medical specialists evaluate the safety, the efficacy, and really the psychological impact of localized estrogen therapy for transgender men who are experiencing testosterone-induced mucosal atrophy.
It's a very specific demographic, but it highlights so much about medicine.
It really does. So if you are listening to this and wondering how a doctor even begins to navigate that conversation, you are in the right place. We are doing a deep dive today, unpacking a stack of clinical guidelines, specialized protocols, and healthcare data to figure it out.
And we really have to evaluate this through multiple lenses because the physiological reality is incredibly complex on its own, but we also have to look at the psychological lens.
Right, you can't separate the two here.
Exactly. Understanding how a specialist balances the urgent need for physical symptom relief with the patient's overarching gender-affirming goals, I mean, it requires a completely different kind of clinical toolkit.
Okay, let's unpack this, because before we can even begin to talk about how a doctor evaluates a treatment, we have to understand the biological reality of the condition itself.
Yeah, the foundational biology.
Right. What is exogenous testosterone actually doing to this localized tissue to cause so much damage?
Well, to get to the root of that, we have to look at how the endocrine system functions under gender-affirming hormone therapy.
Okay.
When transmasculine people take testosterone, that external or exogenous testosterone acts as a dominant signal. It effectively overrides and suppresses the body's natural estrogen production factories.
Specifically the ovaries, right?
Right, exactly.
Which is the intended goal for the patient. Like that suppression is what stops the menstrual cycle, allows the voice to drop, and promotes facial hair growth.
It is the intended systemic goal, absolutely.
Yeah.
But it creates this unintended localized crisis
Wow, okay.
because the vaginal and mucosal tissues are incredibly estrogen dependent. Estrogen is essentially the architect of that specific environment.
So it's building and maintaining the whole area.
Pretty much. It dictates the cellular turnover, it maintains the collagen, and it keeps the tissue thick and elastic. So when you remove that estrogen, the tissue goes into a deprived state.
And the sources say that closely mimics the physiological changes seen in cisgender women going through menopause.
Yes, it very closely mimics it. The clinical descriptions of this atrophy are honestly harrowing when you read the protocols. The tissue literally changes its architecture.
Yeah, I read that it becomes thin, pale, and loses what clinicians call rugae.
Right, the ruga.
Those are like the natural sort of accordion-like folds in the tissue that allow it to stretch without tearing.
Right, exactly. The structural integrity just completely collapses. Clinicians refer to the resulting tissue as friable.
Friable, meaning it just sort of crumbles or breaks easily.
Yeah, it means it is so fragile that even the slightest friction causes micro tears and bleeding. It completely loses its ability to self-lubricate, which leads to severe dryness.
Ugh, that sounds awful.
And in some presentations, rather than being pale, the tissue becomes hyperemic, meaning it looks angry, inflamed, and just deep red because it is so profoundly irritated.
And if you're putting yourself in the shoes of the patient, the symptoms are debilitating. We're looking at reports of dyspareunia, which is severe pain during sexual intercourse.
And dysuria, too.
Right, dysuria, which is sharp pain during urination. Patients constantly describe their own anatomy as feeling like sandpaper, or they complain of a relentless, localized burning sensation.
Because the entire ecosystem is collapsing.
Yeah.
The primary maintenance hormone is just gone.
I was reading through the clinical data on the microbiome shifts, and I kind of want to bounce a specific study off of you.
Sure, go for it.
So the Drexel University medical blog cited a study comparing the vaginal microbiomes of 28 trans men on testosterone against 8 cisgender women.
Oh, yeah, the microbiome study.
Right. And they found a massive drop in lactobacillus bacteria in the trans men, coupled with a huge spike in bacterial diversity. I mean, I sort of picture the tissue environment like a vibrant rainforest that suddenly experiences this massive climate shift. It dries out the soil, it changes the flora. What is exactly happening to the bacteria in this rainforest when the estrogen drops?
To understand the mechanism, it really helps to think of lactobacillus as a specialized security force for that specific mucosal environment.
Okay, security guards.
Right. But, security guards need to be paid. In this ecosystem, estrogen provides the paycheck.
Oh, interesting.
Yeah, so estrogen causes the epithelial cells to produce a sugar called glycogen. The lactobacillus consumes that glycogen, and in return, they produce lactic acid.
And that acid is what keeps the area safe.
Exactly. That acid keeps the local pH low and hostile to dangerous pathogens.
So if the testosterone suppresses the estrogen, the glycogen paycheck basically bounces,
Yep.
and the security guards quit.
That is the exact sequence of events. And once those lactobacillus bacteria die off, the pH level rises. The environment becomes alkaline.
Which throws the doors wide open for harmful bacteria.
Exactly. Opportunistic, harmful bacteria just move right in, which explains that spike in diversity you mentioned.
Wait, so high bacterial diversity is a bad thing here?
In this specific bodily environment, yes. High bacterial diversity is actually a sign of dysfunction. It perfectly explains why these patients are so highly susceptible to recurrent bacterial vaginosis, cystitis, and severe pelvic infections.
Because the natural defenses are just completely dismantled.
Exactly.
Well, since the local tissue is effectively starving, the obvious biological answer is to feed it.
Right.
Which brings us to the treatment dilemma. The recommended clinical protocol is to prescribe localized estrogen to a patient who is actively taking testosterone.
Yeah.
How does a specialist even begin to evaluate the safety of that? And perhaps more importantly, how do they convince a patient that it won't just reverse their transition?
So the clinical evaluation of safety hinges entirely on pharmacokinetics.
Okay.
Specifically, tracking how a drug moves and absorbs within the human body. The patient's primary fear is systemic absorption.
Because they don't want it in their bloodstream.
Right. They are terrified that if they use an estrogen cream or tablet, it will enter their bloodstream, trigger breast tissue growth, redistribute their body fat, and completely derail their masculinization.
Which would trigger massive psychological trauma and gender dysphoria. So what specific treatments are specialists reaching for that avoid that?
They are borrowing directly from postmenopausal care protocols. Specialists generally prescribe highly localized topical estrogen.
Like what, specifically?
Well, the guidelines highlight preparations like Vagifem or Vagirux, which are tiny 10 milligram tablets inserted directly into the mucosal canal, or Ovastin, which is a 0.1% topical cream.
But let me push back on this a little bit. Even if the blood tests prove the physical safety, meaning the doctor knows it won't feminize the patient,
Right.
what about the psychological safety? One of the healthcare blogs highlighted a case study of a patient who experienced severe dysphoria just from a doctor suggesting estrogen.
Yeah, that happens a lot.
Like the mere word felt like a failure of their transition. How do doctors evaluate if the treatment is psychologically safe in that room?
What's fascinating here is how the definition of evaluating safety has to expand far beyond blood panels. Psychological safety is established through incredibly deliberate, informed consent and transparent communication.
It's all about how you talk to the patient.
Exactly. The case study you're referencing pointed out a major systemic failure. Many patients are never warned that vaginal atrophy and incontinence are common side effects of testosterone therapy.
Oh, wow. So if you don't know a side effect is coming, you just assume your body is broken.
Right, rather than just reacting normally to a medication. That lack of preparation breeds a lot of fear.
So how do they establish that safety?
To establish safety, the specialist has to walk the patient through the literal math of the treatment to reframe their understanding.
The math.
Yeah. The clinical guidelines stress that systemic absorption of these specific topical treatments is negligible. So a doctor might sit down with a patient and explain that using this localized estrogen tablet consistently for an entire year results in roughly the same systemic absorption as swallowing just a single 1 milligram estradiol pill.
Wait, really? One single pill spread out over 365 days?
Yep.
Wow. That completely reframes the risk. If the systemic footprint is truly that microscopic, the psychological barrier is essentially just a communication issue, not a biological one.
Exactly. It shifts the patient's focus away from the highly triggering concept of estrogen and refocuses it on the concept of targeted relief.
Right.
Once the patient conceptualizes the treatment as like a localized lotion for a localized dry skin issue rather than a systemic hormone replacement, the psychological safety profile improves dramatically.
Okay, let's assume the doctor successfully navigates that conversation and the patient consents to the treatment. We have established that the hormone stays local. How do specialists measure if it is actually working? Like, what does efficacy look like in the exam room?
Well, clinical efficacy is first measured by the physical reversal of the atrophy. The specialist evaluates the tissue for revascularization.
Meaning the blood flow is back.
Exactly. Healthy blood flow has returned, turning the tissue from pale to a healthy pink. They measure the local pH to ensure it has dropped back into that acidic, pathogen-hostile range.
Bringing the security guards back online.
Right, signaling the return of the lactobacillus. And they look for the thickening of the epithelium and the return of elasticity.
And I imagine from the patient's perspective, efficacy just means the burning stops and the recurrent urinary tract infections disappear.
Yeah, because the barrier function of the skin is finally restored. Symptom relief is obviously vital, but the most critical metric for evaluating the efficacy of this treatment isn't actually about the symptoms at all.
It isn't.
No, it is about access to care.
Here's where it gets really interesting, because the sources reframe this tiny, localized treatment as a gateway to life-saving health maintenance. Yes.
Severe untreated atrophy can make routine preventative medicine completely impossible.
It creates a physical barricade to vital diagnostics. Transgender men who retain a uterus and cervix require regular screenings.
Like ultrasounds and stuff.
Exactly. They need pelvic ultrasounds to check for endometrial hyperplasia, which is an abnormal, dangerous thickening of the uterine lining that can lead to cancer.
Oh, wow.
They also require routine cervical smears. If the tissue is friable and inelastic, attempting to insert an ultrasound wand or speculum is excruciating.
It causes severe tearing and trauma.
Exactly.
And it's not just the physical pain of the speculum either. The sources point out that testosterone-induced atrophy actually degrades the cellular samples themselves.
Yes, that is a major, major clinical hurdle. When a doctor performs a cervical smear on atrophied tissue, the resulting cytology report frequently comes back as inadequate.
Meaning they can't even read it.
Right. The cellular structures are so dehydrated and degraded that the pathologist in the lab literally cannot read the slide to screen for cancerous changes. So a specialist evaluates the true success of this topical estrogen by prescribing a short, intensive course, perhaps a nightly application for 4 to 6 weeks.
Exactly.
And if that short course plumps, hydrates, and heals the tissue enough to allow the doctor to perform a painless exam and extract a medically readable sample, the treatment is deemed a success.
You are utilizing a microdose of a suppressed hormone to unlock the ability to screen a high-risk patient for cancer.
That's incredible.
And this is especially vital when you consider the historical context. Trans men frequently avoid these exact preventative screenings.
Oh, yeah, I can imagine.
The combination of intense physical pain during exams and a widespread lack of cultural competency among medical providers, it just creates a massive barrier to care.
So borrowing these treatments from menopausal care and using them to unlock cancer screenings sounds like a brilliant clinical adaptation.
It really is.
But as we dig deeper into the sources, this practice exposes a rather glaring blind spot in the medical evaluation process.
Yeah, you are looking at the data gap.
Yes. The Drexel University blog brings up a frankly staggering reality. While the biological mechanism seems completely logical, treating trans men with this topical estrogen is technically not evidence-based medicine.
It's a critical, often overlooked distinction in specialized medicine. Current clinical practice is operating on an assumption of equivalence.
Meaning they assume it's exactly the same thing.
Right. Because atrophic vaginitis in postmenopausal cisgender women and in transgender men on testosterone both stem from a lack of estrogen. The medical community just assumed the treatment protocols should be identical.
But the underlying physiology creating those two environments is totally distinct. Menopause is a gradual, natural cessation of ovarian function as a body ages.
Yeah.
Whereas transmasculine hormone therapy is an active, aggressive, chemical suppression of the ovaries driven by exogenous testosterone in bodies of all ages.
Exactly.
To say those are the same biological environment feels like a massive leap.
It is a massive leap. And because of a severe lack of randomized controlled trials, specialists are essentially flying blind. We lack quantified, large-scale research on the actual prevalence of this specific atrophy within the trans population.
You don't even know how many people have it.
Right. We do not have rigorous data proving the long-term efficacy of topical estrogen, specifically for bodies dominated by exogenous testosterone.
Mhm.
And honestly, most distressingly for the patients, we lack rigorous, multi-decade clinical evaluations of any potential feminizing effects unique to this specific metabolic context.
So specialists are basically trying to navigate a complex modern aircraft using instruments built for a completely different machine.
That's a great analogy.
If they don't have the hard data or the clinical trials, how do they evaluate the quality of the care they're providing?
Well, if we connect this to the bigger picture, it reveals an incredible resilience in modern clinical practice. In the absence of population-specific data, specialists have to rely on a different, highly subjective metric, clinical empathy. They evaluate the efficacy of their care by how successfully they can adapt their environment to the vulnerable patient sitting on the exam table.
And the guidelines are actually incredibly specific about what that clinical empathy looks like in practice. It basically translates to trauma-informed care.
Absolutely.
Because the doctor knows the exams are likely painful and they know the scientific data is thin, they actively adapt the physical process. Like, they offer self-taken swabs for STI screenings, allowing the patient to bypass a physical exam entirely if they choose.
Yeah, that autonomy is huge.
Right. And when an internal exam is absolutely necessary, they utilize pediatric-sized speculums or even proctoscopes to minimize stretching. The sources even say they will often hand the instrument to the patient, allowing the patient to insert it themselves so they maintain total physical control.
And clinical empathy also extends heavily into the vocabulary the doctor uses. The protocols emphasize that evaluating care means evaluating communication.
Using gender-affirming language.
Exactly. Specialists are trained to actively ask the patient what specific terms they prefer for their own anatomy, or they just default to highly neutral terms like genitals. They purposely avoid heavily gendered anatomical words that could trigger an acute episode of dysphoria during a really vulnerable exam.
So what does this all mean? It tells us that when perfect, double-blind clinical data doesn't exist, true medical evaluation has to evolve.
It does.
It stops being solely about reading a lab chart or a cytology report, and it becomes about treating the entire human being, their physical tissue, their psychological state, and their identity.
The ultimate measure of efficacy in this specialized field isn't just achieving a healthy mucosal lining. Efficacy is measured by trust.
Trust, yeah.
A treatment is successful if it results in a patient feeling safe enough and respected enough to voluntarily return for their next cervical smear or their abdominal aortic aneurysm screening, simply because they trust the provider sitting across from them.
It really is a remarkable medical journey. I mean, we started at the cellular level, exploring how exogenous testosterone wages a turf war against local estrogen, starving the tissue and evicting the protective bacteria.
Yep, the security guards.
Right. Then we waded into the profound psychological paradox of asking a patient to treat the painful symptoms of their transition with the very hormone they are desperate to suppress. And we ended by looking at how healthcare providers have to creatively and empathetically build bridges when the hard clinical science is lagging decades behind the reality of the patients they are treating.
The major takeaway for anyone listening to this is the absolute necessity of critical thinking in medicine. We have to constantly question our medical assumptions.
Absolutely.
Just because a specific medication or protocol is the unquestioned gold standard for one demographic, like postmenopausal cisgender women, does not mean we can blindly copy-paste it onto another demographic, like transgender men, and assume the biological math will work out perfectly.
Right, because it won't.
Medical science must be tailored to the specific metabolic reality of the patient.
It really must. And I want to leave you with one final, slightly mind-bending thought to mull over as we wrap up.
I love these.
So we talked deeply about the security guards, right? How the vaginal microbiome of a trans man on testosterone completely collapses, losing its lactobacillus and shifting into this highly diverse, chaotic bacterial ecosystem.
Yeah, complete climate shift.
Exactly.
Right.
Well, think about your own body for a second. We are entirely covered in and filled with complex microbiomes. If introducing testosterone completely rewires that one localized environment, What is it doing to the other invisible ecosystems?
Oh, wow.
Like, how is a patient's gut microbiome altering its climate during hormone therapy? How is their skin biome shifting?
That is a fascinating question.
Right. What kind of completely undiscovered medical treatments, preventative strategies, or health insights are just waiting to be found if the medical community simply bothered to study these specific populations directly rather than relying on borrowed
It
science?
really makes you wonder.
It makes you wonder how many other medical mysteries are going unsolved simply because we aren't looking at the right environment. Thank you for joining us on this deep dive.